Good afternoon, everybody. At the outset, let me thank Dr. Chandramohan and Dr. Madhu and his team for inviting me for the talk. I'm going to talk about adjuvant therapy in colon cancer. I just happened to hear the chairperson in Dr. Brown's session that we medical oncologists have only capox and Folfox and nothing else. They do so many things. But I'm sorry to disappoint you. I'm going to talk about capox and Folfox only. So that is what we have in adjuvant therapy. So, but yes, I think nothing so great has happened in last 15, 20 years in the adjuvant therapy in colon. There are few negative trials. There have been some fine tuning in the management, of course, of the adjuvant therapy. So let us at least try to know that. So the objectives, I'll talk about stage 3 colon cancer, chemo in that, stage 2, which is a controversial area of role of chemo, and some biological target and target therapy, whether they have any role or not. Let us see that. So we see that stage 1 has excellent prognosis, excellent survival. Stage 4 does bad. It is stage 3 and stage 2 where the survival is around between 50 to 80%. Stage 2 being the most heterogeneous group, where you have somewhere around 60 to 85%. You know that it is mainly surgeons area, early colon cancer, but there is a substantial number of patients who do not get cured with this, and there we play a role. We help at least to better the result. So stage 1, no role of chemotherapy. Stage 4, only palliative chemo. Stage 3, we know that there is a role of chemotherapy. And stage 2, let us discuss some. It's a controversial area. First, I'll go with the easy one, stage 3, where there is no much controversy. You need to give chemotherapy. So it is the evolution of adjuvant chemo in colon. In 90s, we had 5-fluorouracil, 5-fluorocoverine. Later, it came that 6 months is equal to 12 months. Levamisole as an unnecessary. Then in 2004, you have Folfox, and then later Capox, and that is what we still follow. This is the first positive adjuvant study of CA colon. And then thereafter, 5-FU-based therapy became the standard of therapy. You can see that 5-FU levamisole combination has done better than single agent levamisole and or observation. This is the table that collectively puts everything about the results of intergroup 0089. You can see all the numbers are almost same. So what does it tell us? That levamisole is unnecessary. There is no need for high dose leucovorin. Low dose leucovorin will do the job. There is no need for a 12-month chemotherapy. 6 months will do the job. This is all the data from those 18 randomized trials, around 21,000 patients, and 8-year follow-up data that shows that around 10.3% survival benefit with 5-FU-based chemotherapy. Then we have Xeloda also, which is the ZAT trial, which is a non-inferiority trial, which shows that Xeloda, our capecitabine, that can replace 5-FU-LP. You can use, instead of an injectable 5-FU-leucovorin, you can definitely use an oral capecitabine. It is 2004, which was actually a breakthrough. Whereby this polychemotherapy came into the Mosaic study, which had stage 2, stage 3, some 40% stage 2, 60% stage 3 colon cancer, randomized in Folfox and 5-FU-LV. And this is the result. Putting all the patients together in intent to treat, you find that the benefit is only 2.5%. But if you further dissect the data, you see that in the stage 3 group, definitely the addition of oxaliplatin was better. It was 4.2%, but in stage 2, it is only 0.1%. So oxaliplatin is not much of a use in a stage 2 colon cancer. This is the NACB PC07, which compared Flox versus 5-FU-LV. You see that, yes, in the stage 3 adjuvant oxaliplatin has done the job, but when patients of more than 70 years, you have to be cautious, because oxaliplatin has not done very well in patients who are more than 70 years. So this is the cross-study comparison of FOLFOX and FLOX. The results are almost similar if you can see the numbers, the 3-year DFS, the improvement, it is almost same in FOLFOX and FLOX, but the diarrhea was way high in the FLOX regime, and neutropenia was more in FOLFOX, but still it was a grade, most of the patient had lower grade neutropenia. It was reasonably managed well. So our practice is usually FOLFOX than the FLOX. So whether can Xelox, can we replace it with FOLFOX? It has its own advantage, Xelox. So here this is the Xeloxa trial, which compared the Xelox regime with 5-fluorocovarin. And you can see that the 3-year DFS was 71 versus 67 favoring Xelox. And the OS at 5 years was 78 versus 74 favoring Xelox. And this was confirmed with the longer follow-up. So yes, the data of Xeloxa was comparable with that of the FOLFOX. It's a valid option to FOLFOX. It has a comfort of daycare. There is no need for a chemo port or a PIC line. So it can definitely, but it sounds easy, but in our clinical practice, we see that Xelox sometimes is more difficult to tolerate than that of the FOLFOX. Capecitabine has its own toxicities. A severe hand-foot syndrome, mucositis, diarrhea is more often seen with Xeloda compared to that of the 5-FU-based regime. So this is the, in a nutshell, about last 20 years in early colon cancer with surveillance. The result is around 50% 3-year DFS. With monotherapy, it is around 60%. And when you add oxaliplatin also, with the polychemotherapy, it is around 73 to 75%. So this table again shows that the OS was almost equivalent, but the best was with FOLFOX. The recurrence risk, yes, definitely it is. The recurrence is more in stage 3 compared to that of stage 2. Then whether chemotherapy does its job, yes, FOLFOX is able to decrease the hazard of recurrence in stage 3 patient, but in stage 2 patient, maybe in first 2 to 3 years, the FOLFOX has done the job, but later you will find that there is no difference between the FOLFOX and the 5-FU in stage 2. As per the nodal stage, this looks a busy picture, but to make it simple, when there are N2 kind of disease, when the node positive and that N2 kind of disease, it is the oxaliplatin-based regime, which has succeeded in decreasing the recurrence and the death rate. And when there are nodes are negative, a 5-fluorocovarin is reasonably a good option. This again shows that in PT3-4 node positive disease, we see that in when only 1 to 3 nodes are positive, for about 5 to 6 years, there is no difference, but the graph gets separates after that. So, but when more than 3 nodes are positive, yes, FOLFOX is giving a better result than 5-fluorocovarin. Some changes came after this IDEA collaboration. IDEA collaboration is, it's all, it was a combination of 6 trials in different countries, 16 different groups. It had different PIs. It was a collaboration of collecting data and then analyzing the data. It was a non-inferiority trial, basically, to compare whether can we reduce the treatment duration to 3 months. So what happened after that? It was the non-inferiority of the 3-month chemotherapy could not be established to 6-month in overall population. But yes, in some planned subset analysis, we found that the capox in 3 months was equivalent to that of 6 months. The low risk group, like in stage 3, the low risk group, like T1, T2, T3, N1 or T4, in those kind of patients, you can actually decrease the duration to 3 months. But FOLFOX of 3 months was not equivalent to that of the FOLFOX 6. So when you plan to give FOLFOX, it is actually 6 months, but when you plan to give capox, a 3 month will also do the job. So stage 2, which is actually a controversial area about the role of chemotherapy. It has only a small benefit with 5-fluorocovarin-based chemotherapy, around 3%. There is no clear benefit with FOLFOX. But can we define a group where actually we can use FOLFOX? That need to be seen. COSAR showed a very small advantage with adjuvant chemotherapy, but there are some of the stage 2 disease which is actually as bad as stage 3 disease. Their recurrence and survival is like that of a stage 3 disease. So these are the group of stage 2 which may require a better treatment. So we know about the risk factors, or the high risk factors, the clinico-pathological high risk factors that we use: T4, obstruction, perforation, LVI, PNI. So we take our decision of adjuvant chemo in stage 2 based on these clinico-pathological factors. There are differences in different groups. So this is a study by the Zhang et al. Where he just it showed that 4 groups here divided: a high risk group with chemo, high risk group with no chemo, low risk group with chemo, and low risk group with no chemo, depending upon the clinical pathological factors. So what we actually find is that when the high risk group, a group which has some 1 or 2 risk factors and they don't receive chemo, the cumulative recurrence rate is high in this group. So these are the group actually may benefit from chemotherapy. So we have already seen in the mosaic data that FOLFOX was definitely not superior to 5-fluorocovalent in stage 2. And if you see the late follow-up data, in the high-risk group, yes, FOLFOX is reasonably doing well in the high-risk group. So this is a study which has actually tried to find out the role of chemotherapy with the harvest of lymph node in the surgical sample, and with the number of lymph nodes harvested. So let us see what it is. It was observational, a retrospective actually study, a meta-analysis which has around 1,30,000 patients. What we find it that over the time, definitely there have been a good improvement in the lymph node harvesting. The surgeons have become better. The pathologists have also improved in finding out more lymph nodes in the surgical sample. If you can see that if you have a less than 12 lymph nodes, you decide it is a PT3N0 or based on less than 12 lymph nodes, and you don't give them chemotherapy, then the survival rate is less. It is around 54%, but you give them chemotherapy, it is around 80%. So you may be thinking that it is a T3N0 disease, but actually it may not be, because you have not got the actual number of lymph nodes. And this study shows that from the US National Database that chemotherapy decreases the hazard of mortality by 43% in PNI also. But here, if you can see, it shows a conflicting data. We know that having high risk factors is going to decrease the result, but adding, us in this stage 2 case, stage 2 diseases with or without risk factors, we don't find much difference with addition of chemotherapy. So we have this conflict of data in different studies. So why it is so? Because I think there comes the role of the biological and the clinical pathological markers. So it is not just about TNM staging. There is something beyond TNM staging which is going on inside those cells. It may be the MSI status that we have very much incorporated to our clinical practice now. Here you can see that if MSI high, which is considered as a good prognosis, and in stage 3 with MSI high, if you only give a 5-based chemotherapy, it is a reasonable result, but in stage 2, the result is decremental. So we can actually think that's a stage 2 disease. It's an early stage disease. You have MSI high, which is a good prognosis. Let us de-escalate the chemo, but it won't work like that. Just giving single agent 5-FU is not an option in MSI high. If at all you want to give chemotherapy, it has to be an oxaliplatin. But most of the MSI high nowadays, we don't give chemotherapy based on, we know that they are a good prognosis. They don't require chemotherapy. Other factors which may actually affect your adjuvant results are BRAF, which is very bad, KRAS mutation, which is very bad. Anup had already discussed about the molecular subtypes, so that doesn't need discussion. So stage 2 is the one where you actually require a detailed discussion with the patient about the risk versus benefit, the toxicity associated, the MSI status, and also the age of the patient. As I had already discussed before, that oxaliplatin-based chemo do not offer you much advantage in more than 70 years of patient. So this is a flow chart to show how to treat these stage 2 cancers. If MSI high, you can avoid chemotherapy, but many of us still practice that if you have some risk factors after MSI, we offer many patients, depending upon the age and performance status, we may offer chemotherapy. Yes, MSS, they'll require chemotherapy if they have risk factors. If no risk factors, they can be kept on follow-up. Stage 3, definitely they require chemotherapy. It is only about 3 months or 4 months, depending upon the low risk and the high risk of the disease. So we know about the molecular markers, but these are more of investigational. As of now, we don't use it in our clinical practice. ctDNA there's much talk about ctDNA. After surgery, if there are circulating tumor cell DNA, then they'll do bad compared to that, those don't have. But these all are investigational now. Any role of target therapy, I'll just finish my slides. Bevacizumab, no, it has, there are 3 large negative studies, NSABP, AVANT, and QUESVAR. VEGF, we know that around more than 50% of the CRCs will express VEGF. When high expression of VEGF is going to give more of distant mid and lymph node status, it is not good. But adding VEGF in adjuvant setting has not given us the result. It's a negative trial in NSABP C008 is a negative trial. The AVANT study was also a negative trial. They have done, if you can see the change in hazard ratio in DFS, in first year or something, they have done reasonable job, but as the time passes, we see that it has not given us the result. The possible explanation may be a potential rebound effect of the angiogenesis after you stop the bevacizumab, and it may induce a tumor dormancy. Cetuximab, it also has a negative study, N0147, Folfax plus minus cetuximab, both in KRAS wild and mutant. The study was negative. PTAC-C8 was also a negative study with cetuximab. So I think I'll stop here. This is one targeted therapy, the trial which is going on in BRAF V600 mutation and corafenib and cetuximab. Results are yet to get. I think I was given 13 minutes to finish. I'm sorry, I've just taken a few minutes extra. Thank you.
Thank you so much. Any questions from the...
I think it is Folfox and Capox, to keep it simple, for adjuvant therapy. And yes, we have incorporated MSI into our treatment now. It is basically surgeon's area, and we have actually come down in our treatment from 6 months to 3 months in many of the patients, from single agent, from polychemotherapy to single agent. Many MSI we are using so that we can avoid the chemotherapy. Yes, sir.
No. Sorry, I've got so many queries, and you get such a good presentation. So why stop at only Capox and Folfox?
Yes,
why
yes.
not give triple therapy, FOLFIRINOX? The only trial for rectal cancer which would improve survival is not because of TNT, it's because of triple therapy, FOLFIRINOX. You see the other trials itself which have been done.
That is neoadjuvant.
Yeah.
That is
even
neoadjuvant.
for adjuvant, suppose if you wanted to do, have they tried out triple therapy?
It is very toxic, sir. FOLFIRINOX, we use it for many other cancers. It is a very toxic regimen. So I don't think FOLFIRINOX is going to give you any benefit now.
For neoadjuvant?
Neoadjuvant, yes, there are studies going. There are cases where you can give, you have a data of neoadjuvant in some of the colon cancers. They can do good.
Okay.
We have a lot of work going on the stage 4 setting. There's a lot of role of medical oncologists, but stage 2 still remains the same.
Thank you, Dr. Shahid.